My name is Hannah Pickard, and I want to thank you for joining me today for the second session of Living in Pain, the class that I'm co-teaching with Dr. Travis Reeder. So I want to start just by giving a bit of orientation to what I'm going to talk about today and why. So Travis, 2 days ago, gave this really wonderful talk, which is very much based on his own personal experience. And what I'm going to do today is quite different because it's mainly going to be a theoretical talk which tries to bring together the understanding of addiction that I've developed by working in a very interdisciplinary way for about 10 years now. So in some sense, I'm going to give you a panoptic view of how my own understanding of addiction has evolved. But I thought I would say to begin something just about the personal genesis of this research project of mine, because some of what I'm going to say today is controversial and isn't in line with the orthodox model of addiction as a neurobiological disease. And I think it's helpful, therefore, to preface it by saying that my interest in this topic and the way in which I started to question that orthodox model really came out of my own experience of working for a decade in a specialist service for people with personality disorders and complex needs in England, many of whom struggled with different forms of addiction. And prior to that work, I had no reason really to ever question or think in any way critically about the disease model. I accepted it straightforwardly. And then when I started to do that work clinically, I guess I found two things that really have been the genesis for this research project of mine. The first was that model just wasn't true to my experience of trying to figure out how to help people. So it wasn't a helpful model for me as a clinician to be using. But the second thing was that it wasn't true to the experience of the people I was trying to help either. So there was this real mismatch between the kind of understanding that seemed productive and correct in that clinical encounter and the kind of understanding that just in virtue of living in our world I had picked up. And that, in a sense, really is the roots of the research that I'm going to present to you today. Now, if I can change slides. So just to give you a sense of what's going to happen today, very roughly, the talk's going to fall into 4 different parts. I want to start by really trying to explain what I think of as the puzzle of addiction. So what is it about addiction that we want to explain? And when we have explained, we'll have a good theory of addiction. And to do that, I'm going to look at different models of addiction, different ways we might approach that puzzle. I'm eventually going to suggest how to solve it. But part of that solution is going to focus on the way it's not a one-size-fits-all kind of thing, that there's heterogeneity in the explanations of addiction, and that heterogeneity is incredibly important to recognize if we not only want to understand addiction, but want to treat people who are addicted to the best of our ability. So that's very roughly the outline of what I'm going to do today. But I want to begin where everyone begins, which is with the orthodox model of addiction, which is a disease model. So the model which is currently endorsed by really all major bodies, the World Health Organization, the National Institute of Health, the National Institute of Drug Abuse, sees addiction as a chronic relapsing neurobiological disease that's characterized by compulsive use despite negative consequences. So that just is the standard view of what addiction is. And within this model, there are 3 core concepts. There's the idea of neurobiological disease, there's the idea of compulsion, and then there's also, lastly, this idea of negative consequences. And interestingly, nobody ever talks about negative consequences. They're sort of pushed to one side. But I actually think if you want to understand what addiction is and why it's so puzzling, that's where we need to start. That in ways is the key thing we need to have in mind when we're thinking about addiction, which is that it's drug use that persists despite these negative consequences. So what are they? So they involve things like severe mental and physical health problems, right, that are consequent on drug use or the way in which drug use intersects with other bits of one's life. They involve things like loss of employment, loss of housing, loss of family, friends, loss of community, terrible reductions in self-esteem, tremendous shame. So there really are a series of really significant and harrowing ways in which drug use can affect people. Now, it's a kind of common sense rule of thumb that we use all the time to understand ourselves and understand each other, that we act, so far as possible, in our own best interests and in the interests of people we care about. So if you know that an action of yours is going to bring about terrible negative consequences and you cannot do it, then you don't. That's what it is to act in your own self-interest and the interest in people you care for and who care for you. But that is what addicts don't do, right? So despite the negative consequences that follow upon drug consumption, they persist in using drugs. And that really is what I think of as the puzzle of addiction, what it is that wants explaining. Why are people continuing to use drugs given the negative consequences, right? We would expect them to stop given these consequences, and yet they persist in using. Now, there are many reasons why the orthodox model of addiction as a neurobiological disease has become so influential. Some of them are political and strategic, and I'm going to talk about those in a little bit. But I think one of the reasons for the influence of this model is that it has this tremendous theoretical virtue, which is that it solves the puzzle of addiction, the puzzle of why people keep using despite negative consequences, in an incredibly simple and parsimonious way. And to put it straightforwardly, the explanation is this. Well, if addicts could stop using, then they would stop using, but they can't, which is why they don't. And they can't because they're compelled to use because they have a brain disease. So that explanation, which the disease model offers us, is tremendously powerful and explains what would otherwise be irrational, puzzling, nonsensical behavior. So it's a real virtue of the account. But the problem with the account is that there's increasing evidence that it's simply empirically false, that addiction is well characterized by the idea of compulsion, when that's understood as an irresistible desire, a desire that makes you do something, that compels you to do something, so you really can't not do it. And what I want to do now is just talk to you about the different kinds of studies and evidence we have, which suggest that within addiction, despite the fact that we have a puzzle, which is to explain why people keep using despite negative consequences, this idea of compulsion is just inaccurate. It does not characterize what we find people actually doing. So, as I say, there's a range of evidence. I'm not going to talk about all of it, but here's a flavor. So first of all, both from clinical work, but also just from common sense experience, we all know of cases where somebody does just go cold turkey, they just stop. And that kind of ability simply to stop is complemented by large-scale longitudinal epidemiological studies, which show that the majority of people with a diagnosis of substance use disorder, including dependence, physical dependence, typically mature out by the time they're in their late 20s or early 30s without any clinical intervention. So the majority of people with the diagnosis just stop using. We know that sometimes rates of use are cost sensitive, and indeed some people will choose to stop so as to reduce their tolerance levels so that it doesn't cost as much to use. There are a range of treatments now called contingency management treatments, which basically motivate abstinence by offering positive reinforcement or reward for drug-free urine samples. So the original studies were done with people with cocaine use disorder, and the rewards varied from money for a drug-free urine sample to things like a prize or vouchers to go to a movie with your family, or even a draw and a lucky dip. More recently here at Hopkins, Ken Silverman in the Department of Psychiatry has harnessed this into a really powerful treatment for polydrug users, which involves offering the opportunity of employment for drug-free urine samples. So the incentive there is actually a really important incentive and a chance to have a job and do something really substantively different with one's life at that time. And it's been very effective. So abstinence can be motivated by offering a kind of good, a reward for abstinence. It can also be motivated by offering a punishment or a negative reinforcer. We see that in the effectiveness of some drug courts and also employers like airlines, where they impose very heavy penalties on pilots or staff, including job loss, obviously, if they struggle with drugs and come in and fail a test. Lastly, there are forced choice experiments. Some of these have been done with humans. So Carl Hart from Columbia University did a series of experiments where he brought people addicted to crack cocaine into his lab. They were not high at the time, and offered them a choice between money or a hit there and then. And what he found is that there was great variety in what people did. They often took the money, even sometimes when it was worth less than the value of the drug in front of them. So, you know, there was a lot of variability in what people chose to do when given that forced choice. And in ways, my favorite bit of evidence, and something which I'm happy to talk about later today or on Wednesday if people are interested, comes from animal models. So early on in the 20th century, use of animal models to study addiction, they were thought to support the disease model, because it was found that if you put a rat on its own in a cage with unlimited access to water, food, and cocaine, what in effect happens is it takes the cocaine until it dies, cocaine being an anorectic, which suppresses thirst and hunger. So the rats would simply keep using cocaine. But over a series of really ingenious developments and experiments, animal models researchers realized that if you change the context, so you offer rats who are basically on an addictive trajectory a choice between a drug or another reward, they take, in the majority of instances, the other reward. So there are some very well-controlled studies where if you offer sugar or saccharin or a sort of desirable food as a reward, 90% of the rats take that other reward as opposed to the drug. And recently, this extraordinary study came out of Yavin Shaham's lab at the National Institute of Drug Abuse, where he found that irrespective of kind of drug, dose of drug, length of time since last dose, gender of rat, female rats typically prefer drugs more than male rats. 100% of these rats, when the reward was a social reward, so they were given a choice between a drug and a social reward, 100% took the social reward. And these were rats who were socially housed. They were in no way socially deprived. So in some sense, the really flat-footed way of putting what we learn from animal models is this, that we think of ourselves as having more capacity for self-control and reflective ability than rats. But when rats who are addicted have a choice between drugs and another good that they prefer, they choose that other good. So surely if rats can maintain choice despite long-term drug use, which has an addictive-like profile, one would think that humans can too. So summing all this up, the evidence really suggests that compulsion isn't a good way of characterizing the behavior we find in addiction. Choice is in some sense retained. But having said that, I want to just qualify it in two ways that are really important. The first is that nothing I've said denies the way that cravings are absolutely central to the lived experience of many addicts and a really important part of any theory of addiction. If you crave something, it makes you really want it, and it makes the costs of not having it high. So it is in itself an incentive to use, which any incentive not to use is then going to need to be weighed against. The point is that we can acknowledge cravings without thinking that they compel use. The evidence I just put forward to you suggests that they don't. And this is really important to understand, in part because when I give this talk, sometimes people say, well, hang on, we never really meant by compulsion that it was impossible to resist. We just meant that it's hard to resist. That's all compulsion means. And I guess my sense is the answer to that is that, of course, it's hard to resist. We all know that. The problem is that if you soften the meaning of compulsion so that it just means, well, people have cravings and so it's really hard for them to resist, you lose the explanatory power of the disease model that I said earlier was such an important virtue of it. And you lose it because if it's just hard to resist, then given the consequences that follow from using, we really need to know more. We need to know why people aren't resisting using, given that they could. So in some sense, that softening of the idea of compulsion to cravings that are hard to resist, of course, it's accurate. That's a really important part of addiction, but it loses the explanatory power of the model. The second really important point here is that all of the evidence that I've adduced speaks to what's true of a general theory of addiction. In general, compulsion is not an apt characterization, but it doesn't allow us to infer anything about what's true of a particular person on a single given occasion when they use. So all of us are, in general, able to do things which sometimes, in some contexts, we really can't do. That includes people with addiction as much as anyone. And so, although this tells us that, in general, compulsion is not an accurate characterization, we really don't know what's going on for any particular individual at any instance in time. That remains to be discovered. Okay, so with those two caveats, the sort of take-home messages of the talk so far is that addiction really is characterized by negative consequences. That sort of what helps us focus in on what it is that's puzzling and needs explaining. It's not characterized by compulsive drug use, okay? So compulsion isn't an apt characterization of addiction. So the question is, perhaps, is it a neurobiological disease? And the first thing to say about this is that the fact that compulsion is not an apt characterization of addictive behavior doesn't mean that it's not a disease. They're different concepts, and addiction could be a disease of choice or a disease of cognition. So I immediately want to make it plain that nothing I've said so far tells us that it's not a disease. But nonetheless, I think we should be more thoughtful about this than typically we have been. Now, the dialogue around addiction and the disease model, particularly in the US, is often plagued by a failure to clearly distinguish whether we're interested in this because we really want to know whether addiction is a disease, or whether we're interested in this because we want to secure various pragmatic consequences we think will follow if we label addiction a disease. And this is a really important distinction, right? Because it could be that it is a disease and actually the consequences of labeling it that way are terrible, or that it isn't a disease, but the consequences of labeling it a disease are good. So I want to pull these apart and start by talking a little bit about what we know about the consequences of the disease label. Now, when Alan Leshner and other scientists at NIDA first introduced the disease model, it was very clear, this was in the 90s, that part of the motivation was the idea that it would reduce stigma, that it was going to be a very important political and public tool to reducing stigma and enabling us to treat addiction and people who struggle with it better. But a few decades on, the reality is the effect of the disease label in the US and of biogenetic labels for mental disorders generally in the world has been mixed. One of the good things that's come about is increased public and political willingness to fund research and offer treatment. So that has been something which seems like it's connected to a shift in perception that the disease label has augured. Additionally, it seems like it enables people who are in relationships with people who struggle with addiction to feel less inclination to attribute personal fault and responsibility. And that can be an incredibly important and healing thing for individual relationships. But as against those two virtues of the disease label, interestingly, there has not been a decrease in stigma or marginalization and isolation and other markers we think connected to stigma. And if you just pause and think about this for a moment, that's actually something we might predict because in general, diseases can be highly stigmatized. So think, for instance, of leprosy or HIV/AIDS. The fact that something is a disease doesn't necessarily mean it's not something associated with stigma. In addition, for people who struggle with addiction themselves, it seems like the acceptance of a disease label frequently increases their pessimism about the prospects for recovery, produces a sense of hopelessness, and because of that, decreases their sense of actually being able to do something about the problem and therefore produces less good outcomes than they might otherwise have. So, in a very real sense, the disease label has been a mixed blessing, and whether it's good or bad seems to depend in part who the audience is, right? Who is it who's taking it up and using the label? And that's a really precarious position because it's really not possible not to use the label when talking to patients, but to use it in public or with families or when talking to politicians because we all live in the same world, right? And speak to each other ultimately. So, you know, the value of it when we think of it pragmatically is mixed, and it's very unclear how to resolve that. What now if we turn to the more scientific or theoretical question, what evidence is there that addiction actually is a disease? Well, the first thing to say is that to assess that question, we really need two things. First of all, we need an account of what a brain disease is. So we need to know in general what a brain disease is. And then we need to know whether addiction counts as a brain disease, given the definition we've offered. So there's a lot of controversy within the philosophy of medicine and medicine itself about how to think about the nature of disease and what disease is. But here's an attempt to articulate something that I think we tend to mean from a common sense perspective when we use the notion. We mean something like this. Something's a brain disease when there are these observable symptoms symptoms that people experience, that others or doctors can see in them. And when those symptoms are explained by the presence of underlying brain pathology, that's when we have a brain disease. And there's a very nice model for this idea in the history of psychiatry, which is tertiary syphilis. So in the 19th century, psychiatrists realized that sometimes the collection of symptoms, including paranoia, confusion, and grandiosity, which can actually be present for different reasons. They can be drug-induced, they can be caused by schizophrenia, but sometimes that collection of symptoms was explained by the fact that the patient had tertiary syphilis. Tertiary syphilis is caused by a bacterium, T. pallidum, and it's tertiary when it has moved through the system to the brain. And you can treat it by giving antibiotics and therefore eliminating the bacterium. So we have a really nice model of how these observable psychological symptoms, grandiosity, paranoia, and general confusion, are explained by brain pathology, namely the bacterium that's entered the brain. Okay, so if we use that as a general model, and now we ask, well, is addiction a brain disease? The first question we need to have an answer to is whether the brain changes which we know are caused by long-term heavy drug use really do count as pathological or dysfunctional, or whether they are just natural learned responses to the drug. And to have an answer to that question, we need to know how the brain is supposed to function. My guess, to be honest, is that some of the changes probably do count as pathological, but what I don't think we've done is yet produced a clear account of what the norms around brain function are, which allow us to interrogate that question with the sort of scientific care that it needs. So the first thing we need to see is whether brain changes, which are caused by long-term drug use, but of course, which are caused by many other things we do as well. If you learn to read and start to read, there are changes in your brain. So whether the brain changes particular to addiction really should count as pathological or dysfunctional. That's the first thing. The second thing is whether they're explanatory of the symptoms. Now, what are the symptoms? Well, I think the main symptom is persistent drug use in the face of negative consequences. And again, the picture I want to paint for you today is that those brain changes may sometimes be explanatory of that symptom, but that there are a whole range of other considerations which sometimes really are the cause, as opposed to whatever's happening in the brain, of why someone is persisting in using despite negative consequences. So my own sense is that from a purely theoretical scientific perspective, putting consequences to one side, we should at present be agnostic about whether addiction is a brain disease, and we should be open to the idea that sometimes it might be and sometimes it might not be. Right, now, having said all that, I want to come to one more question and then pick up the rest of the talk again, the narrative of the talk, which is, well, does it matter, right? How much does it matter whether or not you think addiction is a brain disease? And certainly my experience is that people think it matters because they're scared that if it's not a brain disease, we're going to have no way to ward off stigma, blame, shame, and the other ways in which we treat people very badly in our society when they struggle with drug use. And Travis gave a kind of very eloquent illustration of that in his talk 2 days ago, when he described being in the hospital, coming out of this incredibly painful surgery, being inappropriately under-medicated, and being treated with suspicion and sort of stigma, and actually kind of shamed by the clinicians who were engaging with him, labeled as a drug seeker. Now, one thing you might do is try to tell those clinicians, don't do that because somebody who's seeking drugs has a disease. But here's another thing you could do. You could say, look, the fact that we're unsure about the person's status as having a disease. And the fact that they may be using drugs and partially out of choice doesn't mean that you have to behave in such a way as to blame and stigmatize and shame them. So just as we can acknowledge the way in which choice is retained in addiction, we can also acknowledge the way we have a choice in how we respond to people who use drugs and struggle with addiction. And so we can do better as a society and as individuals in relation to drug users, whether or not we're convinced that they have a disease. Okay, so summing up where we are so far, the puzzle of addiction in general is really why keep using drugs given the negative consequences? But once we've removed compulsion as an explanation of that puzzle, and we've wondered about the appropriateness of a disease label, the puzzle really becomes very sharp, because it's a puzzle which now necessarily involves choice. Why keep using drugs given the negative consequences if you have a choice? And that's the question I'm going to try to answer in the rest of the talk. But I want first to take a step back and ask a different question, which is actually an extremely easy question to answer, and which we need to have in focus if we're going to be able to answer this harder question. And the easier question to answer is, why do people use drugs at all? So why do people use drugs? The answer to that is that drugs serve a range of functions which bring benefits to people's lives. And those functions are variable, and they are to some extent drug specific, but they involve things like this. So Travis spoke a lot last class about relief from pain. We can add to that relief from stress, fatigue, boredom, negative emotions like sadness, anxiety, and psychological suffering generally. The drugs that typically serve those kinds of functions are opioids, also alcohol, also sedatives. Next function, improved physical energy and cognitive ability. The drugs that often serve this function are amphetamines, but others as well. Heightened social connectedness and sexual experiences. Here again, we have a range of drugs that can include alcohol and opioids, but you want also to add drugs like MDMA into that list. Mind-altering and self-altering experiences. This can include spiritual experiences. There's been a lot of work recently on psilocybin in particular, but the class of drugs commonly called psychedelics can do this for people and have extraordinary meaning for them in their lives. Finally, there's the function of euphoria, hedonia, and getting high. So in general, drugs bring pleasure, and all the drugs I've named bring pleasure. I'm going to add one more function, which we're going to talk about at the end, which is providing a sense of self-identity and social community. But nonetheless, the thought here is that prior to addiction, there's no difficulty explaining why people use drugs, because drugs have tremendous benefits which we value, and that explains why people use them. Now, this is such an important point, and it's important because once you see that, you recognize that there's only a puzzle of addiction. There's only a question about why people are using drugs when it looks like the balance between the benefits and the costs have tipped. And rather than having these benefits associated with it, it now looks like it has these costs. So it's precisely this tip from drug use having benefits to drug use really being defined by its costs that marks the transition from being a recreational user, a heavy user, into addiction. Okay, so this is a really important point, and I want to illustrate it with Keith Richards, who some of you from my generation may remember very well. So Keith Richards was an avid drug user. He was unquestionably dependent on various drugs at various points in his life. But he famously said that he didn't have a problem with drugs. He only had a problem with policemen. So what does that tell us about Keith Richards? Well, he valued the experimentation and exploration and experiences which drugs gave him. And he was willing to accept the costs of drug use for those benefits. Now, what costs a person faces in relation to their drug use is not something that's just internal to them, like how dependent they are or how much they experience craving. It's something which is always going to be relative to context. So in Keith Richards' case, one of the costs he actually faced was criminal sanction. He was put in prison at various points. That's a kind of cost that a user in the US or the UK or Canada faces, not, for instance, a user in Portugal where drugs are no longer criminalized. But Keith Richards also had this other feature of his life, which enabled him to protect himself against many costs, which was that he was wealthy. So when he faced criminal charges, he could get defended by great lawyers, and he could, for instance, travel with an excellent doctor. So as and when he had genuine physical health needs because of his use, he could be cared for appropriately. Many people, of course, don't have that wealth, and they don't have a way of protecting themselves against the social and otherwise imposed costs of drugs that they incur through using. But what Keith Richards really illustrates for us here is that how you judge when the balance between costs and benefits have tipped, so costs of drug use are exceeding benefits of drug use, is really relative to individual values, which vary between people, and also contexts, which also vary between people. So there's sort of no one-size-fits-all solution to this puzzle. What we always have to do to solve it is to figure out how a particular person is weighing up drug costs and drug benefits in their decision-making, such that at the moment of choice, the balance tips towards consumption and away from abstinence. And again, to pick up on a theme that Travis introduced on Wednesday, one way of understanding this is as marking the distinction between dependence and addiction. So Keith Richards was unquestionably, as I said, dependent on various drugs at different points in his life. This meant that he was subject to withdrawal if they were removed, and no doubt also subject to craving. But he didn't experience himself as addicted because despite that dependence, for him, the benefits nonetheless exceeded the costs. And so in some sense, that distinction between addiction and dependence really depends on keeping the idea of there being negative consequences to use as opposed to just benefits squarely in view. Okay, so I said I was going to solve the puzzle, which is to explain how use persists despite negative consequences when people have a choice. And I've now said that what we have to do is think about how a person is weighing costs and benefits in their decision-making so that in the end, the choice to use looks better from their point of view than the choice to abstain. And what I just want to do now is suggest that there are two basic ways we can turn that trick. We can figure out how someone's thinking about drugs. One is to note that if we actually think of ourselves from within the perspective of an addict's mind, it's often the case that the costs of drug use can be hidden to them, while the benefits are especially salient. So the first way we can solve the puzzle is show how, from an addict's perspective, they're seeing all benefits and no costs. But the second way we can solve the puzzle is to explain how, from our perspective, from the perspective of outside observers, we may see only costs and no benefits. So what I want to do now is talk you through these two different kinds of solutions and then wrap up. So the first kind of solution really depends on thinking about what are known what's known in cognitive science as decision-making biases. So these are an absolutely standard part of human psychology. We know that some of them are augmented, typically in users of certain classes of drugs. But what they all serve to do is focus on the benefits and remove the cost from decision-making. So the biases are things like this. Personal exceptionalism. It won't happen to me. Other people's lives will go downhill from using, but I'm going to be the exception to that rule. Reflection impulsivity. This is the idea that you can take more or less time to make a decision. Addicts typically take less time to make a decision. They decide whether or not to use this on the spur of the moment, and that means they haven't had the opportunity to think through the longer term costs of using. They're just focused on the benefit they would get in the here and now. Delay discounting. This is a ubiquitous feature of many kinds of addiction, and the basic idea is that people focus on immediate reward and discount the value of whatever reward they would get in the future. So with respect to addiction, if you use drugs, you get a reward in the here and now. If you abstain, you might or you might not get a reward of abstinence in the future. So if you're focused on the present, you'll always choose to use drugs. And the kind of common sense motto that can explain this way of thinking is a bird in the hand is worth two in the bush. That's the idea. I've recently done some work with a cognitive neuroscientist called Aaron Bornstein on the mechanisms by which we use our memories to affect our present choices. And the basic idea is that one of the things we do is not just sort of objectively trawl through our past experiences to come up with the most rational decision. What we do when we're thinking about what to do in the present is look for a really, really sort of salient individual experience from the past to guide us. And in the case of people who are addicted to drugs, those early past rewarding experiences are incredibly salient and vivid and can easily come to mind and bias a present choice. So they're thinking, if I use now, I will get that experience like I had way back then. And that's known in sort of addictive folklore as chasing the first high. Finally, there's the idea of denial, which especially in relation to alcohol, is very much a prominent part of our folk psychological understanding of addiction. Interestingly, it has no role whatsoever in the disease model of addiction, but we know that addicts are frequently in denial. And what denial does, of course, is to block the idea that there are any problems associated with drug use, that you do incur any negative consequences. And of course, if you're not seeing that you have any negative consequences from using drugs, those consequences can't figure in your decision making to give you a reason not to use. So in effect, all of these cognitive biases can serve to solve the problem by showing how within addicted decision making, the benefits of drugs are very, very salient and the costs are minimized or completely hidden from view. Okay, so that's one way of solving the puzzle. The other way of solving the puzzle is to think about the way we may be blind to certain benefits. And this is what I want to end on, because I think it is a place where, in some sense, there's some very interesting work to be done, which involves interrogating our own assumptions and facing up to some things that are quite hard to face up to. And meanwhile, a sort of much more deeper and real understanding of addiction can come into view. So I want to talk briefly about three things. One is self-harm. The second is the kind of psychiatric and socioeconomic context in which most addicts live, many addicts live. And the last is self-identity. Now, I'm going to just say the tiniest bit about self-harm. The patient population that I used to work with engaged in a lot of self-harm. And what I always find when I try to talk about it is that nobody wants to. So I've given so many talks about addiction, it's hard for me to know how many at this point, and I'm rarely asked any questions about self-harm. But I think this is extraordinarily important because it is a mindset which characterizes people in our society. And when you have a mindset which is self-destructive and self-hating, then certain actions you take which are harmful to you are things you desire. They're things that you want. At least in some sense, they count as benefits in the moment, not as costs. Now, it's incredibly complicated to acknowledge and try to understand how people could end up in a self-harming, self-destructive mindset. And that's a really important thing I think we need to start to do more of, is to understand the forces which can make people feel that way about themselves. But if someone has that kind of mindset, then the negative consequences that come from drugs or from other forms of reckless behavior or from deliberately cutting or harming themselves, in a sense, count as benefits. So once we recognize that, we have a straightforward solution to the puzzle. As I say, it's a very painful and hard thing to recognize, but it does straightforwardly solve the puzzle. The second thing I want to mention is psychiatric comorbidity and socioeconomic circumstances. So I said earlier when presenting the evidence against compulsion that the majority of people mature out by their late 20s and early 30s. That raises this really important question, which is, who doesn't? And the answer is that on the whole, it's people who come from underprivileged backgrounds and have limited educational and employment opportunities, are often subject to discrimination and stigma, live in poverty, and have a range of comorbid mental health problems. Now, for people with those problems living in that context, drugs are the one thing that can offer relief from some of the worst of life's suffering. And if you take those drugs away, it's not like the good life suddenly appears. You don't take away drugs or choose not to use, and all of a sudden you have a job, you have status, your relationships are repaired, your mental health problems go away. So the other way of solving the puzzle, I think, is to be real about the genuine difficulties in life circumstances that many people live in who struggle with drugs, and the value of drugs in relieving the suffering that those circumstances and problems create. And until we're real about that, we won't see why some people persist in using despite negative consequences, because the truth is, in those circumstances, that may be the rational choice. Okay, the final thing I want to just touch on, see how much time I have left, is the idea of self-identity and social community. And I want to sort of introduce this by a really simple, lovely study, which the psychologist Rob West, who works at University of London, conducted informally, maybe a decade ago now. So Dr. West has had a group of people who had just quit smoking. They were long-term smokers who had just quit smoking in his lab as part of a different study. And he just asked them, by the by, do you consider yourself a smoker or an ex-smoker? Now, within a year, say about 80% of people who quit smoking will be smoking again. And these were people who had been long-term heavy smokers for decades. So objectively, nobody has the right after you've quit 2, 3, 4 days to call yourself an ex-smoker. You've always been a smoker. The chances are you're going to be smoking again. But he found this really interesting thing, which is that 50% of the people who, a few days after quitting, called themselves ex-smokers were not smoking 6 months later. 0% of the people who called themselves a smoker were still not smoking 6 months later. So unless somehow the ex-smokers somehow knew they had cracked the nut, this particular quit attempt, the really natural hypothesis is that the act of identifying as an ex-smoker helps to make you into one. Okay, so that hypothesis has in fact been confirmed in research since then, which shows that identifying as an ex-addict and valuing that self-identity is correlated with recovery, with less sort of substitute unhealthy behaviors, with higher self-esteem. So it looks like it's playing a positive functional role. But it raises the question, and the question is this: so what happens then if someone identifies not as an ex-addict, but as an addict? And here's the last thing I want to suggest to you today, is that that identification gives an incredibly straightforward explanation of why someone would keep using drugs despite negative consequences. The explanation is that they self-identify as an addict, and that is exactly what addicts do. They use drugs despite negative consequences. But it raises the question, why would someone self-identify as an addict? What value could there be in self-identifying as an addict? Now, the first thing I want to say is that if we're interested in answering that question to solve the puzzle of addiction, we're so far from a disease model, and that very fact is worth pointing out. And I think the answer to this question is incredibly rich and complicated, but I want here today just to give you two bits of it to sort of see the shape that this answer could take. So the first bit of the answer is to note that for some people, their identity as an addict is connected to the only social community they had. So I said earlier that Yavin Shaham had done these experiments where he gave rats a choice between drugs or social reward. They all took the social reward. For many people who've lived with addiction in the long term, there's not a choice between drugs and social reward. If they want social reward, it's paired with drugs. So I've chosen this picture to illustrate this idea, not because it's shocking, although in ways it is. This is a picture of two men who live in the Bay Area who are long-term polydrug homeless users, where one is helping the other by giving him an injection in the neck, which is a dangerous thing to do and something you only do when most of your veins have collapsed and are no longer able to take the needle. But I think one of the things this picture shows, in addition to that, is the kind of trust and tenderness between these men. And I recommend the book from which the picture has come if you're interested in this element of addiction. It's called Righteous Dope Fiend, and it's based on 10 years of field work within this community, done by Philippe Bourgoin and Jeff Schoenberg. But the thought here is that for many people, the relationships they have with other users are rich and real and important to them. And if they stop using, they lose those relationships. And it's not as if we as a society tend to welcome them back and replace those relationships with others of equal value and worth. So one of the reasons why an addict identity can have value is because it brings social community. Now, the other reason that I want to end with is the idea that it gives you a sense of who you are. And without it, there's this existential question, which is, who would you be? Now, this is a long quotation, but it's worth at least reading some of it to try to get a feel for this. It's by an addict who started very young and then went into recovery and is now reflecting on that process. And she says, just as a person can feel loss of identity when they lose a job or their children have grown and left, it's also common, she thinks, to feel loss of identity when recovering from a drug-addicted lifestyle. She had established herself as a druggie, and her friends and family knew her as such, and she had a lot of street smarts. She was good at using compared to other people, and that was something she was proud of. And then she notes that seeing as she'd not done much else with herself in the years of early adulthood, she didn't have much else to her sense of identity. And when she began to leave it behind, it felt like there was nothing to equate herself with. There was a real void. So it wasn't that she missed the druggie lifestyle, but that she lost a grip on who she was and was finding it hard to function. And she notes at the end that although she wants to encourage anyone who's dissatisfied with the drug-chasing lifestyle to change it, you have to want it, and you have to work at becoming someone and something else. Otherwise, you're still empty and your inner self is left craving and wanting. So we all need to know who we are. A sense of who we are is a fundamental kind of thing for all of us in our psychology. And an addict identity is something that sometimes people can be anchored in and can give them a sense of pride. And to give that up, they have to find another identity. And typically that process of finding another identity isn't just done on the snap of a finger. It takes a lot of work and it takes a lot of support from others. So again, given that, that's another reason why somebody would continue to use despite the negative consequences, because without their addict identity defined by that pattern of behavior, they don't know who they are. So what we need to do to help a person like that is offer a bunch of resources which I see as good in themselves, but also the scaffolding for the creation of an alternative self-identity. So drawing this to a close. If the picture I've painted today is even along the right lines, there are sort of 3 points that I want to end with. The first is that there is no single thing which addiction is. It's an incredibly heterogeneous concept because although in each case it's defined by persistent use in the face of negative consequences, the explanations of why someone is behaving that way are incredibly individually variable. And because they're variable, and because to understand why someone's keeping using despite negative consequences, we need to understand why they're making that choice, we actually need to be real about the value of drugs to people, even when they're deep in addiction. And finally, the take-home message is that that's a really important point, not just for research, for understanding addiction, right, but also for treatment. Because the way in which you're going to try to intervene to help someone who's continuing to use because they're really struggling with cravings and finding it hard to control themselves, as opposed to someone who's in denial, as opposed to someone who self-identifies as an addict and doesn't know who they would be if they give up that identity. The way you are going to intervene to try to support and help those 3 people is entirely different. So unless we start to recognize the heterogeneity of addiction, we are in effect tying our hands in our ability to help people.